I think that the main concerns GPs will have around priority setting is to make sure they do the job well, in the sense of ensuring they're not creating a situation in where they're at conflict with the interests of their patients and they're being seen to be explicitly rationing services. So I think they'll be concerned to make sure they have the mechanisms in place that have the expert support so they can look at the evidence, that they're involving the public in influencing that decision making, and that they can have a transparent process that stands up to that rigour of public accountability.
And in terms of emerging consortia, what should they be doing now around priority setting?
I think it's really important that they understand the functions that are going to transfer to them in the whole. Clearly one of those important functions is priority setting. So I think they need to be getting familiar with what that responsibility means. They need to understand what good examples of practice already exist, and they need to ensure that they're not doing that in isolation, that they're talking to colleagues in other parts of the country, talking to colleagues in public health that have expertise in priority setting, to make sure they're taking on board the very best models of practice in partnership with their future colleagues to get the very best local solutions.
And we've heard a lot today about the dual role for GPs, first of all being a patient advocate and secondly commissioning for their local population. How do you think GPs should manage this in the future?
I think this is one of the great benefits of the reform in terms of moving the role of a GP from being an advocate for an individual patient, where often that patient will come and see me, and actually the sort of decisions that we need to make about their healthcare and the services available to them may not be available, and I feel I don't have the influence to bring about that sort of change. So for me, having the responsibility for the whole budget, therefore for the whole, I guess, the health of the population as opposed to the individual patient, I think that then gives me the opportunity not only to be an advocate for the individual patient to get the best out of the system, but actually to work with partners across the system, including the public and patients, to improve the sort of choices that are available. I think this unlocks the richness that exists within involving a number of clinicians and the public in redesigning services, getting better value for money, great health outcomes and a great patient experience.
And what would you say to fellow GPs who perhaps feel quite apprehensive about taking on a new commissioning role?
I think if you're not feeling apprehensive, I would tend to suggest you haven't really understood the size of the task. So I think apprehension is good. I think fear drives many people to success. I think it's important that you are seriously looking at what the role is going to be, but recognising that you haven't got to do this on your own. There's expertise from a management perspective. There are other partners within their health economy, consultants, there's a local authority, public health, there are other GPs, lots of people who are going through this together. And I think there's a lot that we can learn from each other to ensure that we turn the fear of failure into success.
Now we've heard a lot today about the process can be done quite well and that's certainly been done in PCTs, but they've had real problems with implementation. Now you've spoken a bit about involving stakeholders, but how else can GP commissioners make sure that they're able to implement those decisions they make?
I think this has been one of the difficulties that we've had with the existing relationship, that there's often been a disconnect between the commissioners who are making decisions around priority setting and then the clinicians on the ground who are either implementing those decisions or are the public face with patients in terms of trying to explain those decisions. So I think this connection between clinical commissioning and GPs and actually other clinicians from specialist areas, community areas, wherever, getting more involved in the decision making so that they understand it at a clinical level. They're able to communicate that more effectively to all health professionals so that we have a collective responsibility in that prioritisation, not simply ensuring it sits with just a few. I think that opens it up for more people being able to contribute and influence those decisions. But I also think clinicians would gain a lot of heart if we were able to communicate those priority decisions more effectively to the general public. So when there is a discussion between a patient and a clinician, we're coming with a much more similar level of understanding, and it doesn't feel like the clinician is having to say no to a decision the patient could have been aware of,
before
they started to engage in decisions about their healthcare.
Now, we've talked a lot about what can happen at a local level. What can be done in the national policy arena to help GP consortia to prioritise the healthcare that they commission?
I think it's really important that when we're providing advice around commissioning outcomes for emerging commissioning consortia, that we're doing that against the same sort of accountability that the commissioning consortia will have. So if we're looking at the sense of managing a population, having a budget that encapsulates all the healthcare for the population, then if I'm going to be receiving advice from NICE from a commissioning perspective, I'd very much like them to be helping me work out where I can invest the money wisely within my budget to get the very best health outcomes. And that means looking at the whole breadth of investment in health, in public health, in keeping people fit and well, not simply in medical interventions. So I need that advice that helps me look across the whole spectrum of health, not simply focusing on specific interventions.